there today. So the first will be from Care Cochin, 07. Okay. The chairpersons for the event are Dr. Shanmuhanandam, and the judges for the event will be Dr. Glaston Chalaya, Dr. Narasimlu sir, and Dr. Professor CPR sir.
Good morning. Shall I start?
Yeah, please start. Okay.
Good morning, everyone. The study was on effectiveness and tolerability of apremilast in psoriatic arthritis, a single-center study in Ernakulam district. The aim of the study was to study the effectiveness and tolerability of apremilast in patients with psoriatic arthritis. It was a single-center longitudinal prospective observational study among psoriatic arthritis patients who were prescribed with apremilast in the period of November 2017 to September 2018. The inclusion criteria was the patients of 18 to 70 years of age diagnosed with psoriatic arthritis as per Casper criteria and treated with apremilast, and those patients who were on DMARDs were included if they were on stable dose of DMARDs or biologicals for at least 12 weeks. The exclusion criteria was patients who lost follow-up before 16 weeks and who were receiving phototherapy or any topical therapy along with apremilast. 135 patients were screened, and among them 15 were excluded because of incomplete data and lost follow-up. A few patients couldn't even tolerate a single dose of apremilast. They were also excluded. And among the 120 patients which were included, 31 patients were on apremilast monotherapy, 70 patients were on non-biologicals with apremilast, and 19 patients were on biologicals with apremilast. When we look into the patient baseline characteristics, mean age were 48 years with 32% females with an active arthritis of TJC7, SJC2. 30 patients had spine involvement with a mean BASDI of 4.3 with a mean ESR of 31. 46.7% had dactylitis and 32.5% had enthesitis. When we look into the baseline DMARDs, 79% were on baseline DMARDs with majority of 38.3% on methotrexate. When we look into the results, when we look into the change in the PASI score, both monotherapy and combination therapy, there was significant reduction in PASI score. The monotherapy from 7.3 to 2.3 and the combination therapy from 4.58 to 1.543. When we look into the arthritis part, there was significant reduction in TJC, SJC, early morning stiffness and PGH. The 30 patients, that is 25% had spine involvement and 56% had BASDI 50% response in 16 weeks. In the study, around 28.3% had adverse events, mainly were nausea, diarrhea and gastritis. 16.6% tolerated the reduced dose of apremilast, but 11.6% had to discontinue the drug because of mainly GI intolerance. So in conclusion, in this prospective study, apremilast was found to improve the skin, improve the arthritis and improve the spinal involvement. Combination with other biological DMARDs and conventional DMARDs appeared to be safe. GI intolerance appeared to be the major side effect, and considering the safety and efficacy, apremilast may be considered as first-line agent in the management of psoriatic disease. The limitation of study was mainly the score of dactylitis and enthesitis was not done in the study. Thank you.
You have not separated into various groups?
Separate?
Into various groups, each how much is the component? Whether combination of biologics increase the side effect or that analysis?
No, side effect profile, it didn't increase the side effect profile.
Okay.
With biologicals, with apremilast, it didn't increase.
But don't you think 30% is a high incidence of side effects? 30%?
Yes, yes.
At what dose did you observe the diarrhea?
Diagram?
The gastrointestinal side effects.
What?
At what dose of apremilast did you observe the gastrointestinal side effects?
Some even didn't, even for the 20 mg, they had side effects. But 30 mg apremilast dose, when the dose was reduced to 20 mg, some tolerated that dose and they were continued on that dose also.
So open to the judges.
Yes, sir.
What are the different types of psoriatic arthritis? The details you didn't mention. Polyarticular, oliarticular, psoriatic spondyloarthropathy.
25% had spine involvement. The rest had only peripheral arthritis with skin involvement.
So in the inclusion criteria, the apremilast works different in peripheral joint disease and in the spinal disease, isn't it?
Yes, sir.
So what was your inclusion criteria? Because you have not clearly defined.
According to Casper criteria, all the patients were taken in.
Casper criteria is for psoriatic arthritis, that is for peripheral inflammatory arthritis.
Yes, sir.
But how did you manage to combine with both spinal involvement and Casper?
Those who had spinal involvement didn't have single spinal involvement with skin. They also had the peripheral arthritis, both
So
together.
So is your study in patients who have psoriatic spondyloarthropathy with peripheral arthritis, or it's pool of things? Then if it is pool of things, how could you come to a conclusion that this and this works?
No, that was not there, I think. I didn't understand, sir.
No. When you set up a study, you have inclusion criteria. So it is because apremilast, the drug, what you know, works in a different way in peripheral inflammatory joint disease and spinal disease. So how did you manage to get?
Spinal component, only 25% had, sir.
So then how did you make a result that combination treatment and monotherapy works in?
That was baseline, whatever the patient were on. We took DMARD naive patients, on biologicals patients and on DMARD patients. All were taken in.
Do you think it's going to be a valid paper when you write it in a journal?
The enthesitis score and dactylitis score was not
No, that's
taken.
okay. Thank you.
Thank you, sir. Spinal involvement, yes, sir. Bastide 50% was, in 16 weeks, 56% had Bastide 50% response.
What criteria have you taken? Sarcolic arthritis. What are the evaluation criteria?
What are the
Sarcolic arthritis, what are the evaluation criteria you have taken to say improvement? Symptoms, signs, radiologically, what are the...
Bastide. Only Bastide was being taken.
There are no more questions. We shall move on to the next presenter. Determinants of hydroxychloroquine response in cases of palindromic rheumatism. Dr. Clint Bass will present.
For next slide, you can press this.
Good morning, everyone. I'm Dr. Clint Bass, Junior Resident, Department of Clinical Immunology, and my guide, Dr. Paul Tierney, Head of the Department of Clinical Immunology. We did a study on determinants of hydroxychloroquine response in palindromic rheumatism. And about palindromic rheumatism, it is characterized by acute episodic arthritis, which may last from few hours to a week. Various drugs have been used to treat palindromic rheumatism with inconsistent results. Few studies have shown that the use of antimalarials in patients with PR is associated with the reduction in frequency of episodes. But still, the exact treatment strategy for PR is unknown. The objective of our study is to assess the response in patients with palindromic rheumatism. and to find out the predictors of response. So we did a prospective cohort study in 100 patients diagnosed as palindromic rheumatism based on the criteria proposed by Guerin and Wiesman, and put on hydroxychloroquine in clinical immunology OPD, Amal Institute of Medical Sciences, Thrissur, for a period from January 2017 to May 2019. Patients diagnosed as PR were started on hydroxychloroquine alone, and treatment response was assessed at the end of 6 months. Participants who had at least 75% reduction in the frequency of episodes with hydroxychloroquine were selected as responders, and others were taken as non-responders. We included all patients of all age group who fulfilled the diagnostic criteria of palindromic rheumatism, and patients satisfying the ASIA 2010 criteria for other rheumatic diseases, those who had followed up less than 1 year, and those with episodes less than 5 per month were excluded from our study. And now moving on to the results. We found that we have 70% of our participants had good response to hydroxychloroquine, and also we found that we were able to reduce the frequency of episodes by a percentage of 80 to 90%, and it's like nearly 8 to 10 episodes per month to nearly 1 to 2 episodes per month. We were also able to reduce the use of NSAIDs by nearly 13 NSAIDs per month to 1 to 2 NSAIDs per month. And we found that males responded better when compared to females to hydroxychloroquine. We also found that younger age group people responded better to hydroxychloroquine when compared to the elderly. And now about the duration of illness, we found that patients with shorter duration of illness had better response to hydroxychloroquine when compared to patients with a longer duration of illness. Now coming on to the inflammatory markers, we found that negative CRP implicated better response to hydroxychloroquine when compared to positive CRP patients, but we were not able to find any significant change in increased or normal ESR values. Now about autoantibodies, we found that seronegative patients responded better compared to seropositive patients, and 82% of our seronegative patients responded better to hydroxychloroquine when compared to seropositive. Even though not statistically significant, we found that ACCP positivity showed worse prognosis to hydroxychloroquine response. Now, our study showed that hydroxychloroquine could decrease frequency of episodes by 80% in 70% of patients, and we were able to decrease the use of NSAIDs. Previous studies by Yusuf et al. And Gonzalez et al. Had 78% and 68% response respectively with antimalarials in treating palindromic rheumatism. Our study showed that HCQ responders were mostly seronegative, and most of our responders had negative CRP values and shorter duration of illness. Previous studies by Mattingly and Saldo proposed that seropositive PR cases have severe disease and they require more drugs. And to conclude, hydroxychloroquine is useful in treatment of palindromic rheumatism, and elevated CRP and ACCP positive are markers for subminimal response to hydroxychloroquine. Determinants of hydroxychloroquine response are younger age, male sex, shorter duration of illness, negative CRP, and seronegativity. So we would like to propose maybe hydroxychloroquine may be considered as first line for palindromic rheumatism. Thank you.
What was the limitation of your study?
We have to have more number of our sample size should be higher, and we are planning to continue our study further to make it 200.
You said about raised CRP
Yes,
and a positive anti-CCP and an episode of joint inflammation.
Yes, sir.
And you also mentioned to me the criteria that you have excluded the patient according to 2010 rheumatic disease criteria. What is that? What do you mean by that, 2010 rheumatic disease criteria. What is that criteria?
Those people that fit into criteria of rheumatoid arthritis.
Will they not fit into the criteria? The ACR 2010 says a single small joint involvement, raised inflammatory markers, symptoms are for 6 months,
Yes.
and with positive serology, they fit into the diagnosis of inflammatory joint disease, isn't it?
Yes, sir.
So that is why when you treat them, they are not responding well, because you are not treating the rheumatoid.
No, we are treating palindromic rheumatism patients. We have excluded all those rheumatoid arthritis patients.
When was the classification made for palindromic rheumatism? What year was the classification made for palindromic rheumatism?
This is 1992.
We are in 2010, isn't it, the criteria?
Yes, sir.
Thank you.
Thank you, sir. Thank you, sir.
Next.
For next slide,
Good morning, one and all. This is a study on demographic, clinical profile and outcome of non-radiographic axial spondyloarthritis in a tertiary care hospital. So, with the background of study that there is a question mark whether non-radiographic SPA itself progress on to radiographic SPA over a period of time, whether it is a prodromal phase. So, we also do not have much of studies on non-radiographic SPA in Indian settings. So, with SAS criteria, we have early sacroiliitis being very much diagnosed. Whether all of them progress on to AS is a question mark. So, we aimed to study the demographic and clinical manifestations of non-radiographic axial SPA at a center to look into any differences between male and female, if any, in this group, and to study the outcome of, which means here radiographic sacroiliitis at the end of 2 years. So, materials and methods, it is a prospective observational study done at our center from April 2016 to May 2019. So, according to ASA's classification criteria, we included patients who had this imaging arm alone, sacroiliitis on imaging plus one of any of the SPA features. We did not include the clinical arm, which means the HLA-B27 positivity. So, none of our patients, so all newly diagnosed non-radiographic SPA with MRA evidence of sacroiliitis was taken, and all of them who had a follow-up of 24 months was included, and HLA-B27 and MRA pelvis was done at the onset for all the patients. X-ray pelvis was done at the onset, 12 months and 24 months if needed in between. X-ray was read by rheumatologist, help being taken whenever needed from the radiologist. The exclusion criteria was a clinical arm of AS which had HLA-B27 positivity with any of the clinical features, 2 of the clinical features. We did not include them. So, HIV positivity, irregular follow-up and not completed 2 years as on May 2019 was excluded. The disease activity measure used in this study was BASDAI, which was done at 0, 6, 12 and 24 months. So, in the results, out of 83 patients of SPA whom we screened, 43 satisfied the inclusion criteria of a study of non-radiographic SPA who had MRI evidence of sacroiliitis and did not have any X-ray evidence of sacroiliitis. Out of that, males were 32, females were 11, and male-female ratio was in the range of 2.9:1. The mean age of males was 26.85 and females was 23.27. HLA-B27 was found in 65% of non-radiographic SPA in our patients. The baseline CRP was slightly elevated in males, 10.5, and females it was 6. So, none was statistically significant here. So, we had the demographic profile. So, many of our patients were actually on sulfasalazine and methotrexate, and outcome as X-ray evidence of sacroiliitis was present in 4 patients, and all the 4 were males, and almost like 12.5%, which wasn't statistically significant. So, the associated conditions found in our patients were uveitis, psoriasis, IBD and non-specific colitis. So, BASDAI, if we take, so the average BASDAI for the patients who did not progress was like 5.48 to 2.28 at 6 months, then 1.32 and 1.6. We can see at the end of 12 months, there is a small dip, 1.33 in patient, but there is a slight elevation at the end of 2 years. Whereas the radiographic progression with sacroiliitis BASDAI over 2 years since onset was slightly elevated in most of the patients, and at the end of 6 months, it did show a increased feature when compared to people who haven't progressed, because at the end of 6 months, most of them were put on biologics assets, so we can see a dip there. So, who are progressed to radiographic progression to sacroiliitis? 4 numbers, all were males, all were B27 positive. The baseline CRP of all those patients were very high, and baseline CRP of patients who did not have a radiographic progression was 6.4. Then we had a higher batch rate at onset and 6 months. Onset it wasn't significant, but at 6 months it was significant between the two groups. So no statistical difference in HLA-B27 positivity. At discussion, mean age of our patients were in mid-20s. Male-female ratio was 2.9:1, but many of the studies had 1:1 in difference when it comes to NR-SPA. And HLA-B27 of our study was 65%. Most of the studies put it at 78 to 85%. But however, they have included also the clinical arm, which had HLA-B27 positivity as a major criteria. So this was slightly low in our case. So progression to AS in our case was 9.3%, which means it is slightly higher as such. When it compared to many studies, it was almost like equal. But in our study, it was taken only with MRA positivity. So most studies quote high CRP, smoking and B27 positivity. Limitations, 24 months is too short a period to assess the progression of non-radiographic SPA, but many studies have taken this as the minimum duration. So influence of smoking was not studied, and we did not include ASDAS as the criteria of disease activity, and progression to AS was predominantly assessed using sacroiliac joint here. What the study has to, and even with MRA evidence of sacroiliitis at onset, X-ray evidence of sacroiliitis at 2 years was only 9.3%. To conclude, long-term follow-up of non-radiographic SPA will let us know that whether it actually does progress to AS, whether any major predictors of AS is already there, and we also have the chance to look about the hormonal influence of the patient. Thank you. Sir, because there are not many studies in radiographic SPA progression in our population, sir. Most of them talked about the clinical profile, but they did not talk whether it progresses itself or stops at non-radiographic SPA itself. Yes, sir. We did MRA at the onset for all patients.
No, already in the literature.
Literature, yes. Literature, many literature has seen non-radiographic SPA progression over 5 years, 10 years, including both the arms, both the MRA evidence as well as the HLA-B27 evidence. And people have found that MRA people progressed rapidly. But in this study, this did not happen. Even with MRA evidence of sacroiliitis, the progression at the end of 2 years was only 10%. Whether at the end of 5 years and 10 years it's going to increase, we have to look into that.
What is the radiological grading you have done?
So radiology here we have used only the sacroiliac joints. We did not go into the spine because that wasn't the inclusion criteria of a study. Inclusion at the start, we started with MRA and X-ray of pelvis. Again at the end of 2 years also we studied only with the X-ray of the pelvis. We did not include a lumbar spine.
And during the progression?
So most of the patients were on NSI therapy, and which was like usually on-demand NSAIDs. After the initial 2 months of continuous NSAIDs, almost all of them were on on-demand, but most of the patients here was treated with sulfasalazine and if not responsive, methotrexate, which is not there in most of the studies. Most of the studies on axial non-radiographic SPA, it's either NSAIDs or anti-TNF, but in our country we are used to treating them with sulfasalazine and methotrexate, we did use. So whether this drugs also cause this effect has to be studied. Yes, sir.
Then did you deviate from that?
No, sir. It was like we wanted to see the progression also, sir. So that is why we had a baseline radiograph, and also at the end of 12 months and 24 months. We skipped the 6 months duration because we did not want overexposure of X-rays. But okay, 0, 12 and 24 months X-ray also was done. It was done both for epidemiology and just to see the progression of NR-SPA, because I see most of my NR-SPA patients walking around very comfortably at the end of 2 years or 3 years also. So whether does it progress or not, or we are unnecessarily picking up early sacroiliitis and making them label as non-radiographic SPA.
Did you?
You started as an observational study, isn't it?
Yes, it's a prospective observational study.
It's your concept match with that?
Maybe. We do not have a control range as such.
Okay. And You also said that all the sacroiliitis on the MR scan
Yes,
cannot
sir.
be true, which is a known concept.
Yes.
So did you do anything to?
Did you?
How did you make a difference in that?
I didn't get your question, sir. MR evidence of sacroiliitis, yes. That was done by the radiologist. People who had a low backache were screened. MRI evidence of bilateral sacroiliitis or even unilateral.
And in one of the slides, I saw that X-rays are read by the rheumatologist.
X-rays alone, sir. MRI was done by only radiologist.
What is that?
So most of our X-rays are not read by radiologists. They just give the films. So it is up to us to read.
Thank you.
I understand.
That was a question I wanted to ask. Did you have an intra-observer among radiologists?
Ma'am, X-rays are
Did
not,
you,
I mean...
did you blind to radiologists and do the study, apart from us being included?
No. X-rays was not read by radiologist. It was read only
The
by...
next thing is, did you categorize patients, those who received only NSAIDs, those who received NSAIDs with our conventional DMARDs?
Ma'am, at the end of
For
it
a
only
particular duration to say that it got aborted
all
or
these
did
things
not
comes when we had lots of progression to radiographic, but none of them progressed, like only 4 actually progressed. So in that case, almost all of them were either on NSAIDs with DMARDs, and all the 4 who had actually progressed on to radiographic progression was on biologics. They were at some point of time.
Was there resolution or they remain static? You said no progression, so how do you take
not resolution, ma'am. We did not do an MRI again to see whether there was resolution. All we did was an MRI at the first onset, then progressed, see whether X-ray had progressed or not. We haven't repeated our MRI any time of this month. I mean,
if you do HLA-B27 by PCR, would the...
No, sir, flow cytometry.
Would the percentage would have increased?
Sir, in HLA-B27 by flow cytometry, we have certain patients in the quadrants, like in the left upper quadrant, where they put it as indeterminate. So those patients were, we did by PCR, but mostly all flow cytometry because it was slightly cost effective for us.
Okay.
PCR was slightly very costly, 6,000 rupees.
And you have not touched the risk factors, isn't it?
Yes, sir. That is one of my limitations because smoking was a major risk factor, but I did not include. I wasn't very sure that why I missed it.
Retrospectively think, would you design the study in a different way or labeled in a different way?
Maybe it would have been even better. Yeah, thank you. We proceed on with the next presentation. Platform number 10, it is from Ramchandra Medical College. So, an observational study on ANCA-associated vasculitis.
For next slide, replace pannu.
Good morning, everyone. My study is on observational study of ANCA-associated vasculitis from a tertiary care center. The aim is to assess the clinical profile and response to treatment in patients with ANCA-associated vasculitis. It is an observational study, prospective study done at Sziracon Medical Center for a duration of 18 months. The baseline assessment done was clinical and laboratory profile, and the follow-up was done at 0, 3, 6, and 12 months respectively. The results of the demographic profile, the prevalence of ANCA-associated vasculitis was 0.001%. Out of the 5 patients, 3 were female and 2 were males. Mean age of the patient was 45. Median disease duration was 36 months. The duration of follow-up available with our patients, 3 patients we followed up for 12 months, and 1 patient with 3 months and continuing, and one we had 1 death. This is just a pie chart showing the various systemic involvement in our patients, with the commonest being eyes, ENT, followed by neurological and GI, and the other manifestations, all other manifestations. All patients had eye involvement in the form of scleritis and scleromalacia. 3 had limited form of disease. Out of 5 patients, 3 had limited form of disease and 2 had systemic disease. 4 out of 5 patients had ENT involvement in various forms. One rare manifestation that we found was lymphangioma, which was seen in 1 patient. And 2 patients developed hepatitis B infection in the follow-up. And 1 patient had CNS involvement in the form of jugular foramen syndrome. 1 patient had both renal and cardiac involvement as well, in the form of RPG and myocarditis, and the patient also had infective endocarditis. This is just a picture of 1 patient before the treatment, scleritis of the left eye, and the next picture shows the picture after treatment. This is another patient with scleritis, and the other patient on the right hand side showing scleromalacia. This is just an expanded form of the clinical profile. One patient had digital ulcer, one patient had cranial palsy, neurological, and one patient had CVA. 3 out of 5 patients had arthritis. And these are the various manifestation of ENT, and all 5 patients had scleritis. Eye involvement was the commonest finding in our study. And one patient had lymphangioma, and one patient had hematuria with renal involvement, and one patient had myocarditis, and 2 patients had hepatitis B infection. This is just a CT picture showing initially we had a lesion in the right cardiophrenic angle, which revealed lymphangioma after the biopsy. This is the investigation which I have done. 4 patients had PR3 positive with C-ANCA positivity, and 1 patient had MPO with P-ANCA positivity. The treatment and follow-up in a limited variety, 3 patients had limited variety, out of which they received steroids and methotrexate for the 3 months, and mean methotrexate dose was 20.5 mg per week. 2 patients had inadequate response at 3 months with persistent high PR3 titers, so we shifted the treatment to rituximab. Following rituximab, the disease activity reduced, and there were no flares following rituximab therapy. And in systemic variety, one patient with severe systemic symptoms with myocarditis and RPGN, we initially received pulse steroid therapy and cyclophosphamide therapy. Unfortunately, the patient succumbed despite the treatment. And one other patient improved with systemic involvement. Initially, she received steroid and cyclophosphamide therapy, and she had recurrence of disease activity, following which we put her on rituximab maintenance therapy. And with 1 year follow-up, she had no flares following. The major points to ponder in our series are, in our study, all patients had scleritis, and there was one study in Saudi Arabia which showed only 32% of eye involvement, and there was one other study in India which showed, again, the commonest manifestation in AAV was ocular involvement. And in our study, the 2 patients had hepatitis B infection, and in one study in Turkey showed that in chronic hepatitis B group, 31% had ANCA positivity. So the possibility of hepatitis B association with AAV needs further evaluation. And also the rituximab therapy induces and helps in maintaining remission even in patients with limited GPA who are not responding to methotrexate. And regarding the lymphangioma association, I couldn't find any studies associated with vasculitis. So association of lymphangioma in AAV needs to be studied further. So the conclusion, in our study, all patients had eye involvement. Hence, early recognition and appropriate therapy may prevent complications. And 2 patients had hepatitis B infection in our study. Hence, hepatitis B associated AAV needs further evaluation. And rituximab therapy induces and helps in maintaining remission even in patients with limited GPA. These are my references. Thank you.
I have one doubt. What is the manifestation of lymphangioma? Clinical manifestation was there, or incidental detection in imaging?
So regarding lymphangioma, sir, it was just an incidental finding, sir.
Incidental?
Yes, sir.
So how does vasculitis can cause lymphangioma? Any idea?
That's why we couldn't find any studies regarding that, so further studies should be done on that, sir.
Okay.
Associated vasculitis, which disease is that?
Sir, GPA, sir.
Huh?
GPA. Sorry, sir, I didn't get it.
Yeah, P-ANCA associated vasculitis.
Sir,
you said one case is
Yes, sir, yes, sir.
What disease is that, and what eye involvement he had? Scleritis.
That patient also had scleritis, sir. But then he didn't have any history of bronchial asthma, and his eosinophil counts were normal, so we just wanted to, and there was no renal involvement in that patient, so we just wanted to put this as a ANCA associated.
One disease, another disease also is there, is it not?
Okay. So EGPA and MPAs.
What is the message from the study?
From our study, that's what our common manifestation in our patients were the eye involvement, so it has to be caught early, and prompt treatment should be initiated, and further workup should be done. And also the hepatitis B infection seems to be present in 2 out of 5 patients in our study, so that also has to be evaluated. So, like say for example, most of the patients we screen only the HPS-AG, so the core antigen also has to be screened for all the patients.
We know the eye involvement can be up to 100% in ANCA-associated vasculitis, and we know very well the hepatitis B involvement and vasculitis. So, are you agreeing with the concept in your Indian cohort, or are you trying to let us know a different message?
That was in another Indian study as well. There was like 31% patients had hepatitis B positivity, but they haven't screened like completely, so the core antigen and all was not assessed. So I would like to stress that point as well, sir.
Okay, thank you.
Thank you.
We have the last platform presentation for today from Madras Medical College.
For next slide, just this. Okay.
Good morning, everyone. At the outset, I would like to thank the organizing committee and the scientific committee for giving me this opportunity. As my friend from the previous talk, he highlighted the fact that HBsAg evaluation has to be done. So my topic is basically on that, to identify the occult HBV infections which is prevalent among these rheumatic patients. So it was a study, prevalence of occult HBV infection in patients with rheumatologic diseases. At the background, I would like to say there are estimated around 200 crores of world population, out of which around 350 million harbor this virus. The Indian prevalence in various studies have been ranging from around 2 to 8%, and most of them average around 4%. So the presence of HBV DNA in liver tissue and or in the serum in the absence of detectable HBsAg is called as occult HBV infection, or otherwise OBI. So the aim of my study is to evaluate the frequency of occult HB infection among inpatients with autoimmune rheumatic diseases. The diseases included were psoriatic arthritis, spondyloarthritis, rheumatoid arthritis, and various ETDs. The objective was to identify this occult HB infection in these patients and the prevalence in various immunosuppressive medication and what is the level of HBV DNA and the anti-HBC in these patients, and to stratify them into different risk category group for reactivation. So the study was conducted in Department of Rheumatology, Madras Medical College from Jan 2019 to March 2019. Consecutive patients using immunosuppressive agents for rheumatic diseases were initially had already been screened for HBsAg ELISA at the beginning of therapy itself. At that time itself, the liver function test and everything was being done. At the inclusion of the study, we studied their HBsAg levels and anti-HBC total levels were analyzed. And those of whom had total anti-HBC positivity were screened by HBV DNA levels by real-time PCR. So the anti-HBC total was helped by King's Institute Guindy and HBV DNA through our hepatology department. So this was the clinical and demographic profile of these patients. Around 45 females and 27 males were there. The average age was roughly the same, 32 and 31.9. The duration of immunosuppressive exposure, that is, some of them who were included in the study were on immunosuppressives for 1 month, and some of them even almost up to 5 years. So the distribution of various diseases were spondyloarthritis 18, CTDs as you can see 24. So the high risk group is the corticosteroids more than 40 milligram for more than 4 weeks. Only 2 patients were there in our study. Rituximab, around 10 patients were included. Anti-TNF alpha, which comes under the moderate risk category for reactivation, was around 26 patients. Cyclophosphamide and low dose corticosteroids and DMARDs, which come under the low risk category. Almost majority of them were on DMARDs and low dose corticosteroids. Coming to the results, out of the 72 patients enrolled, they were screened for HBsAg and anti-HBC total. All were negative for HBsAg at the beginning and also at the inclusion of the study. 19 of these patients were actually positive for anti-HBC total. Now, out of these 10 patients had actually HBV DNA copies which is less than 100, and 1 patient among them had HBV DNA copies more than 1000. And when we look back into the group of the patient, it was actually a patient who was on rituximab, which has got a high risk of reactivation. Now, the chances of reactivation were divided into 3 risk categories: high risk, moderate risk, and low risk. This is depending on the reactivation potential of these drugs. So 13 patients were in the moderate risk category and 2 patients were in the low risk category in our study. The time delay in identifying this occult HBV infection was ranging from 1 month, and as I said, it was maximum duration of 5 years. Now 73.6% had negative and 18.2% were in the moderate risk group, and HBV DNA levels among the 19 patients who were positive for anti-HBC Only one patient had more than 1,000, predominantly were in the around of 100 to 1,000 range of DNA copies, HBV DNA copies. Now, approximately 350 million people are infected. HBV infection is responsible for 40.2%. The reactivation with biological therapy is much more than the DMARDS therapy. So 19 patients of 72 were found positive to have anti-HBC total in our group, and but majority of them were having less than 100 copies only, but however the time lag ranged for almost 5 years. So anytime during this period they could have a reactivation. So in conclusion, I would like to say of all the immunosuppressive, rituximab tops the list of biologicals increasing the risk of reactivation. We wanted to identify these cases of occult HBV infection. 27% of our patient population were found to have anti-HBC total. So using anti-HBC total along with HBsAg antigen detection can be a good screening test in detecting these cases. Because in a resource poor country, HBV DNA actually ranges from 2,000 rupees to 7,000 rupees, including when the patient is being started on rituximab, if HBsAg plus anti-HBC total is identified, and if they found positive, then go on to do HBV DNA, it is found to be better in preventing reactivation. Thank you.
Why did you take only 3 months duration? You had large number of patients. Could you have increased the duration? Because then it would be more
Sir, to get it done from institutes like because 72 patients already were included, so to get these samples to be sent to Guindy and then to get the results, and because we just wanted to initially screen this number of patients, considering the prevalence, it was coming up to around 60 was the sample size, so we thought 72 would be enough. So in consultation with hepatology, like how many samples they could handle, we just thought, so we are planning to include a lot of other patients and come out with the results.
Why did you do this study?
Sir, actually the prevalence of occult HBV infection in different countries have been ranging in different ranges. That is, some of the countries are low prevalence countries. So these studies have been done in other countries where the prevalence has been low. So they have found out this anti-HBC total is not very useful. But ours is a moderate risk country. So that's why the risk of reactivation in these patients is very high, especially with rituximab. So we wanted to study like where do we stand exactly and how this screening can be bettered by including a new test. The anti-HBC is coming around 1,200. HBsAg is around 350 to 800. So probably we could screen them better.
Do you not screen for hepatitis B before you give them rituximab?
So we used to screen. So all these patients were actually initially screened for HBsAg. They were all negative for these. So some of them.
No, I'm asking why do you do this? And I'm struggling to understand that you don't have the resources to check hepatitis.
So we are doing HBsAg actually regularly for all these patients. So some of them are undergoing rapid test, some of them are undergoing ELISA test. So but we regularly don't do anti-HBC total actually for the patients even who are receiving rituximab. So that is why we wanted to highlight the fact that the inclusion of anti-HBC total for screening before giving rituximab would be useful.
So do you mean to say that all your concept is a pilot concept? Because I can't see any design in this, I can't see any outcome measures, nothing. So.
Yeah, it was just a pilot study. We just wanted to see the prevalence of occult HBV infections.
Thank you.
Thank you.
Thank you, sir.
Thank you.
Close this session. Thanks, one and all.
Mouse, huh? Okay, I'll do it.
We will start the first session of today's scientific session. We have the first session on guidelines in gout management, discordance and solutions. The chairpersons for this event are Dr. C.P. Rajendran, Dr. B.G. Dharmanan and Dr. Abdul Qadir. The chairpersons will chair for 2 sessions, guidelines in gout management and in recent advances in the management of gout.
Good morning. Thanks for coming for the early morning session. We'll begin the program. I invite Dr. Jaswit Singh to deliver a lecture on guidelines on gout management, discards and solutions.
For next slide changing.
So good morning. And again, I'd like to thank the organizers, Dr. Rajeshwari, VK, and others, for giving me an opportunity to share some of my thoughts about gout guideline. I realize we're cutting into the breakfast time for a lot of attendees, but I'm sure they'll pour in as the time goes by. So here are my disclosures. I think the relevant disclosures are that I have consulted for a company that makes one of the gout products, as well as I think I have a lot of intellectual disclosures that are disclosed here. I am one of the authors on the ACR guideline, and we've written a lot of letters in opposition to some of the other guidelines that I'll be discussing. So I do have an intellectual conflict, as you can see. So the three topics that I want to discuss as controversies from various guidelines fall into these three titles. What is the appropriate dose of urate-lowering therapy, and do you need to adjust it for kidney function? Can you drive the uric acid too low? Is there something that's too low, and can that be a problem? Especially the risk of dementia has been brought up in some instances. And then the last one is treat to target, in principle in gout, that's been recently challenged by the American College of Physicians guideline that has introduced a new term called treat to symptoms. So the first controversy goes to ULART 2016, and this is the guideline number 9, and it is about the renal dosing. And my disclosure is that we wrote a letter to the editor along with Tuhina and a lot of our New Zealand colleagues and some other colleagues like Ted Michaels and others who were also co-authors of the 2012 ACR guideline. So here's the controversial part of the guideline that I'd like to share with you the evidence and let you be the judge whether it really matters or not. So the rest of the guideline is fine. I've underlined where I want to contest and where we disagreed with the EULAR guideline. It says that in people with renal impairment, the allopurinol maximum dose should be adjusted to creatinine clearance. And that's the point we disagree with. Okay? So I'll show you the evidence. So this is Lisa Stamp's article, the only article in human biology that gives you any idea about renal function and allopurinol hypersensitivity. There has not been a study before, and there's not been a study since. This is it. It's a retrospective series, 1-to-3 matching, gout patients who developed allopurinol hypersensitivity syndrome, and they had controls that were matched for sex, diuretic use, age, and EGFR. They found 54 cases of allopurinol hypersensitivity, and they found that if you look at the initial dose, that it does matter what your starting dose is. So the starting dose and allopurinol hypersensitivity are linked, okay? Based on this one case control series of 54 AHS, and this is it. There is no other evidence to date. The same authors, a year before this article, published that the allopurinol dose above that based on renal function is safe and effective from another cohort of 90 patients where allopurinol dose was increased monthly to get target serum uric less than 6. They saw rashes in 3 patients. Allopurinol was discontinued. And in 31 of the 35 patients, they actually got the target serum uric less than 6 at 12 months. None of these patients developed AHS. And here's the data that shows you that if you do not dose 50, 100, or 150 milligrams above the creatinine clearance to the maximum dose, you do not get below 6. And the same data are shown right here with regards to percent reduction in SUA. And this is people in whom the dose escalation was done beyond kidney function. It still takes a few months for them to get below 6. Nicola Delbeth had published another article 5 years prior to the 2011 article on AHS, where they also had a similar finding in 250 gout patients. 71% were taking recommended doses. And as you can see in the bottom bullet right there, the 19% on the recommended dose based on kidney function achieved target serum urate. So your chance of success of treat to target is 20% if you go to kidney function for maximum dose. So you have an excellent chance of treating 1 in 5 patients to target if you stick with renal function dosing for the maximum dose, okay? That's what the EULAR recommendation was. And 38% not taking recommended doses, and most of these are above the recommended doses, actually achieve target serum urate. So this is the same data in graphical format from the same study from Nicola. And basically the message is that if you dose it according to renal function, the maximum dose, you have very poor chances of treat to target in gout. So the summary of evidence, the way I see it, is that the starting dose of allopurinol has some link to allopurinol hypersensitivity syndrome based on the single study from Lisa Stamp from New Zealand based on 54 cases of allopurinol hypersensitivity syndrome. That the final dose, if you adjust it to the renal function, will not achieve treat to target. You will not get the serum urate below 6. And based on this evidence that I've shown you, I believe that the final allopurinol dose above that based on renal function is safe and effective and should be done. Okay? So that's my rationale that there is no evidence for that underlying part in EULAR recommendation number 9 from EULAR 2016. All right. The second recommendation that I want to, in the guideline that I want to discuss with you has to do with, can you drive the serum urate too low? And this is EULAR recommendation number 6. And it says on the bottom that the SUA level less than 3 milligram per DL is not recommended in the long term. And what they cited as a reason for this recommendation is the following. They said that some studies, but not all, have suggested that uric acid might protect against various neurodegenerative diseases such as Parkinson's, Alzheimer's, and amyotrophic lateral sclerosis. Given these data and availability of ULT that has a potency to decrease SUA, the task force does not recommending lowering serum urate less than 3 milligrams per DL. And this part I slightly disagree with the underlying part. And I'm showing you here the evidence gathered in this regard as of 2018 June is when I ran this search and wrote an article. And what I'm showing you is that there are studies that support this rationale that you should not lower it too much. But there are studies that say that's not a problem. So you get evidence on either side. It's not that all evidence is lining up on one side. So you have evidence on either side that it may matter or may not matter. What really actually was nice for us is that the first author of the EULAR 2016 guideline published a paper a year later from the French cohort, which actually challenges that recommendation itself. And again, this is an evidence that the science evolves over time. The EULAR recommendation came in 2016, and this is a paper from 2017. So what they did in this study was that they actually is a population-based study of 3-city Dijon cohort. They took healthy older people. This is about 1,600 people, of which 110 developed dementia. This is a very long study. They actually followed these people for 10 years. And the crude incidence of dementia in this French population is about 8 per 1,000 person years. And as they look at the relationship between serum uric acid and dementia in healthy, aging, population-based cohort, you find that the highest quartile of SUA increases your risk of dementia by 80% or doubles your risk. And that's the confidence interval right there. It may be as little as 17% or as much as 300% high risk of dementia if you're in the highest SUA quartile versus the lowest. The association here in this study was stronger with vascular dementia rather than Alzheimer's, and you can see that the confidence interval in the Alzheimer actually overlaps 1.00. So you could say that either that the study does not have the power, and that's why it's a negative finding, or you can say that Alzheimer's dementia risk is not increased, while vascular dementia risk is increased with SUA quartile in healthy, normal aging people. And there's also, actually this study is really elegant because they did MRIs on all these people. So there's actually a pathophysiological correlation whereby there is a borderline correlation between high US SUA and the white matter hyperdensity lesions with a P of 0.10. But they see that only in the areas that you see small vessel disease. And when you look at the lacuna or hippocampal areas, there's actually no correlation. So p-value is not less than 0.05, but do keep in mind that it's only 110 people having dementia, 10-year study, 1,600 people. I'm sure very expensive. I'm sure we can do better studies, but there is an issue of power. And no randomized study can ever beat this study because it's a very long follow-up in a population-based cohort. Now, this does not answer the question for people with gout, but this answers the question in elderly aging population as to what happens and what relationship does serum urate have independent of everything else to dementia. And this study at least suggests that high serum uric acid is not good, but bad, which is opposite to what the EULAR recommendation may say. I'm showing you some data from one of our study where we looked at the US Medicare population. In the US, everybody above the age 65 gets Medicare, and so this is representative of all Americans who are 65 years or older, and we have a 5% random sample. By random sample, the beauty of random sample is it actually represents the entire population because you randomly select from the entire sample. The advantage is that we don't have to pay hundreds of thousands of dollars. The expense of a 5% random sample is about 1/10 of the whole Medicare sample, so we couldn't afford the whole sample, we use a 5% sample. And so we look at incident dementia based on a code. Now remember I showed you the French study, that's actually a prospective cohort study where people are getting MRIs, they're getting clinical exams, they're getting neurological exam. So that study is far more robust than our study. We're looking at ICD codes, and there's some misclassification error in this study. We find that about 2,600 treatment episodes ended in dementia. Mean cohort age is 81 years, obviously because we're looking at only people above 65. And these are people with gout. And we look at neither drug. And when we look at the allopurinol febuxostat exposure, we find that the exposure to these drugs is not associated with the incidence of dementia. And this is the model that shows you that regardless of whether you look at a model that takes into account age, gender, race, comorbidity, statins, beta blockers, diuretics, ACE inhibitors, or adds on top of that coronary artery disease and risk factors, that you actually have absolutely no increase in the risk of dementia related to either allopurinol febuxostat exposure compared to neither. One of the other things that frequently comes up is how to actually dose allopurinol correctly, because often the question is, are you dosing it too much or too little? And I think this is the only study from Rick Wright's group from New Zealand that actually tells us that what we think is wrong, and data actually prove us that we should do the opposite. And I'll show you what I mean by this. Okay? You can see that as your kidney function gets worse from a creatinine, as the kidney function is getting worse from a creatinine clearance of greater than 90 to in the 15 to 30 range, that your dose of allopurinol required does not vary much for you to get to target serum urate. But if you're taking diuretics, you have to double the dose of your allopurinol if your kidney function is bad. Not half it, not cut it down to 25%, but double it to actually get there. So a study that proves that our thinking about dosing of allopurinol in kidney function is exact opposite of what we need to be doing. So if you're interested, you can go and read this beautiful article by Wright et al. And this seems to be data that differs by diuretic use. If you're not using diuretics, you may not need to change it much. And if you look across body weight, it matters that as you go from 50 kilograms to 150 kilograms, your dose doubles, regardless of whether you are in the diuretic or non-diuretic, which we all know that serum urate is a function of body weight to some extent. So the summary of evidence for gout and dementia, in my view, is that does gout increase the risk of dementia? And I think the answer is unclear at this time. I think the gout increases the risk of dementia. This should probably read hyperuricemia increases the risk of dementia in healthy elderly, with evidence of some correlation with lesions on the MRI. And that we know at least there is suggestion from one of our studies that use of serum urate lowering therapies does not increase the risk of dementia. So my conclusion is that there's no conclusive evidence that gout protects against dementia and that urate lowering therapy with some threshold will increase this risk. Is it possible that there is some threshold? I think it's possible. But do we have evidence about that? We don't. The evidence that the EULAR guidelines cited, if you read each of those articles, are actually about serum urate level in people with Parkinson's disease, serum urate levels in people with ALS, and that's cross-sectional or case-control studies. Okay? The last point I'll make in the last 4 slides is this issue about treat to symptoms, which is a new concept floated by American College of Physicians, as opposed to treat to target. So ACP started a new controversy in the field of gout by suggesting treat to symptoms. And they said that there's no evidence for us to have a target. And therefore, we should try something called treat to symptoms, which if you did a Medline search with the day this came online first, there are 6 results if you put treat to symptoms in Medline search, and none of them is a study. So this is a novel concept that's discovered by our colleagues in ACP. And because of that, Tuhina Nyoji and Ted Michaels wrote an editorial accompanying this that challenged this issue that diabetes, gout, heart disease are chronic diseases. You cannot treat to symptoms. We don't treat CAD to angina symptoms and say we're done. We don't treat diabetes to just lowering your glucose and say we are done. We try to prevent chronic complications. We actually give chronic therapy, and that's the same concept that needs to be followed here. We wrote a letter as well that is published in Annals, which challenges and says that there is evidence for treat to target, and it comes from 3 randomized studies that the task force excluded. And as you can see, Paul and Newberry wrote the response that the reason they excluded this is because the primary care physicians do not use pegloticase, and the febuxostat RCT was a post hoc analysis. So that was the response to our letter. So why treat to target? Because we know that serum urate less than 6 is associated with not only reduction in gout flares, but tophi, and also reduces cost. We know that 3 RCTs have shown that lowering of serum urate actually shows higher rate of tophus reduction, febuxostat versus comparator, and tophus reduction with pegloticase versus placebo, and that tophi are associated with a lot of negative impact on quality of life. We know that in a study from Shoji from almost 15 years ago that the risk of gout flares is far lower if you have serum target less than 6 versus over 6, and you have almost about 60 to 80% reduction in flares, and this is quite significant because flares is not something that patients want. And if you look at the pivotal trials of pegloticase that John Sunday published that actually were used for the FDA approval for pegloticase, they showed that not only do you see in the pegloticase monthly group that you have resolution of tophi a little more than placebo, but actually the biweekly you have far more, which is the dose we use. And you see a similar improvement in quality of life and functional status by HAC. So this is the febuxostat data from Becker et al. That also shows that you have less flares in the serum urate less than 6 versus more than 6. We know that allopurinol is one of the drugs that actually is not expensive even in the US. And a 90-day supply from Walmart.com costs $10. So 1 year supply would be $40. And the expense of doing a serum urate once or twice is $40. So we estimate that if you repeated serum urate 1 to 3 times, that you actually get $80 extra for each of the 4 tests. So you have an expense of about $120 for 1 year of therapy and monitoring for gout. It's not going to be a huge expense even by US standards for most of our patients who have copays of several $100s for 1 month supply of several medications for diabetes and heart disease. So the extra expense, which is used, one of the rationale as not excessive monitoring in ACP, does not hold true for this disease. And this is cost saving, I believe, for a lot of our patients. And I'll skip through that and conclude by saying that the reduction of serum urate reduces gout flares. That treat to target has been shown to resolve tophi, improve quality of life function. That the cost of ULT and T2T monitoring are minimal in the US, about $100 for year 1, And that observational study proved that T2 target is feasible and associated with improved outcome compared to not T2 target. We still do need RCTs. I believe that is right from ACP, but I don't think that suddenly we need to discover a new methodology of managing patients for chronic disease than what has existed for diabetes and others. And with that, I'd like to thank the organizers. And for those who are not aware, Tinsley Harrison, who wrote the Harrison textbook of medicine, is actually a physician from my institution at UAB, whose mural actually sits in front of one of the main buildings at UAB. And this is the beautiful UAB campus. So do come and visit us. All the red buildings are UAB, and we gradually are encroaching onto the downtown Birmingham, taking over a lot of buildings from the downtown building. So thank you again, and do come and visit us.
Thank you for the excellent overview of this complex topic. Session is open for a few questions.
What about the dose? 600 milligram, is it the maximum dose? Or for allopurinol, in the guidelines, they say they can go up to 600 milligram. So without diuretics. With diuretics, I find it's 900 or so. Sometimes when you see, even after giving 600 milligram, if the uric acid level doesn't come down, in spite of a normal renal function and diet control. So how do we go about it? Is there any difference between 600 and 800 are going to be the same in such patients?
Sure. So just to repeat the question, Dr. VK, what do you do in a patient who has not achieved target serum urate with 600 of allopurinol and is 600 the maximal dose? The FDA approved allopurinol at 800 milligrams dose in 1968, when the mean BMI in the US was much lower than the mean BMI in the US now. So obviously we know that 800 at that time for people in the US at that time was probably the right dose, maximum dose, but it's probably not now. It was approved at 900 milligram maximum dose in Europe. However, I can share with you that over the last 10 years, I have pushed the allopurinol dose all the way up to 1500 to 1800 milligrams, so 1500 to 1800 without any problem. In some patients, not in every patient. But I frequently will go to 900 dose and sometimes 1200 or 1500 or 1800 milligrams. But most people, I would say about 95% of my patients, once you get to the 900 to 1200 milligram dose, you actually can get them in the target serum urate. And I don't have to frequently push them above 1200. When I do push them above 1200, I tell them that this is a little bit above the FDA or the EMEA approved dose from 50 years ago, but that I and my colleagues have used this dose in a lot of gout patients without issues. So it has to be a little bit more informed discussion. I think the other thing I always bring up with patients is their alcohol intake and also their adherence in a nice way. I don't ask them how often you take the medication. I ask them, I say, most of us forget taking medications every day. It's very difficult to take medications every day. I forget my own medications sometimes. How often do you forget to take your medication? So I give them a sense and a zone of comfort for them to be more honest with me. And that allows them to say, well, my doctor is like me. He forgets his medications too. So I guess I can tell him that I forget it too. So non-adherence is sometimes an issue, but you can easily push it up to 900 to 100 milligram, and the approved doses are 800 and 900, but that's from 1967, when we were much younger. And everybody across the world had a much lower BMI, and people weren't taking as much diuretics, and as you can see with diuretics, your requirement goes quite high because of the competing mechanisms.
Regarding the indication of urate lowering therapy, the BSR guideline says that even with the first episode, you have to start continuous treatment with urate lowering drugs. ACR guidelines say 2 or more attacks per year. What is your comment?
So let me make sure I got your question right. So the BSR guideline indicates that the ULT can be started at the first attack of gout, and ACR says 2 or more gout attacks, right? So when do you start gout therapy? I think So I'm not stating the position, the official position of the ACR. This is just the view of Jazz Singh, a rheumatologist from Birmingham, Alabama, okay? I think that we are gradually evolving into more towards the BSR over time. We don't have studies. We don't have studies of what happens in terms of benefit and risk in people who've just had one gout attack. We would need large cohort studies, and some of them are going to be impossible to do because the time between the first gout attack and the second gout attack may be 5 years, 8 years, 10 years, 15 years. So you have to have a 20-year study to actually look at the benefits and risk of what happens if you do use it and if you don't. That's a very difficult study to do, right? So, but we also know that some patients will actually start having subclinical inflammation, which can be a trigger for cardiac, perhaps CNS, maybe renal, maybe hypertension, and some of the other diseases. As a link between uric acid and cardiac disease, link between uric acid and hypertension, link between uric acid and metabolic disease becomes better defined. And if we find that there's actually a causal link, I think we'll start seeing more support for the BSR type of guideline than sort of waiting for 2 or more attacks a year. My personal view is that any gout patients I ever see who comes to my clinic, my gout clinic, and I know it's gout, I don't have to wait for the second attack. I personally just talk to the patient and say, you have gout, here is crystal proven gout, or here's your marginal erosion, and your second attack has already occurred or will occur, but in the meantime, you're at risk for subclinical inflammation that can have detrimental effect on coronary arteries, maybe on kidney, I'm not sure, the link is not that clear, but for sure it can affect your blood pressure, it can affect some other cardiac outcome, possibly, we don't know the correct link, but there is always possibility, because we're talking about the same inflammation in RA, and suddenly everybody says, yes, it happens in RA. Well, gout is also a chronic inflammatory disease and more common than RA. So if RA is a risk factor, independent risk factor for CAD development, perhaps gout also is. I think some of the gout studies and studies of uric acid and cardiac outcomes have given us evidence on both sides of gout either being a direct independent risk factor versus not being. So that controversy continues, and that's been going on for good 40, 50 years. I think with more randomized trials of urate-lowering therapies and more elegant observational studies, we'll get more clarity. But there's a lot of interest in uric acid in the kidney and uric acid and cardiac outcomes. And you must have seen the CANTOS trial, which was done with IL-1 inhibition in people with coronary artery disease, didn't have gout. And it reduced the risk of recurrent MI in people who got IL-1 inhibition with canakinumab. So there's emerging evidence. Yeah.
Acid above 9 milligram need to be treated.
Yeah.
Asymptomatic hyperuricemia. That is the Japanese guideline. So in the last 7 or 8 years, there were 8 or 9 guidelines from various agencies which add more confusion to the clinician.
So the question is, the Japanese guideline has recommended treatment even for asymptomatic hyperuricemia with serum urate more than 9. And I think that's the one guideline that differs from all other guidelines in terms of treating asymptomatic hyperuricemia. I think every other guideline so far has stated that there is no need or there's no indication to treat asymptomatic hyperuricemia. And that's primarily around the fact that there is some inherent risk of using allopurinol lifelong, right? If allopurinol had no harm and it was free, it would not be a question at all, right? So there is always a small risk of allopurinol hypersensitivity syndrome. The side effects are not much, itching in 5% of patients, and then it's nothing, right? If they don't get AHS and they don't get itching, it's like water supply. You know, you could pretty much give it to anybody, but it's a burden of taking a pill every day. And it's the slight risk of the side effects that I think is the basis of most other guideline committees not recommending this for asymptomatic hyperuricemia. One other point I'd like to make is, again, I think the Japanese guidelines are, I think, a little ahead of some of the other guidelines, and they're generating some data from Japanese populations whereby the link between uric acid and blood pressure in Japanese population seems to be a little bit more robust than what we've seen from evidence elsewhere. But they've not done randomized trials, definitive randomized trials, to show that treating asymptomatic hyperuricemia will actually lower your serum uric acid or lower your blood pressure, lower your blood pressure and cardiac outcomes. And those studies are a bit challenging for obvious reasons. I don't treat asymptomatic hyperuricemia, but again, I think asymptomatic hyperuricemia will get redefined. Because some of the asymptomatic hyperuricemia is asymptomatic hyperuricemia in somebody with risk of coronary artery disease or coronary artery disease. The question is it asymptomatic anymore? Can you tell me that uric acid did not contribute to CAD? Can you tell me that the atrial arrhythmia the patient had, you had no relation with serum uric acid? Can you tell me that the SVT that this 35-year-old had, that the serum urate has no link to that? Can you tell me that their borderline hypertension, according to the new hypertension guidelines from AHA, is not contributed by the serum uric acid? And we don't know the answers to those questions, but I think my own belief is that as we gather more evidence, we might be leaning a little bit more towards a better definition of asymptomatic hyperuricemia to asymptomatic hyperuricemia no comorbidity, and asymptomatic hyperuricemia cardiac comorbidity, asymptomatic hyperuricemia renal comorbidity, asymptomatic hyperuricemia metabolic syndrome, and I think these three we most likely 10 years from now will be treating. This one, and I'm not sure. So that's an excellent question. I think we need to better define this whole asymptomatic hyperuricemia, because that's 20% of the world. That's 1 in 5 people. If there is 50 people in this room, then 10 of them actually have asymptomatic hyperuricemia right now. So it's a very prevalent condition, but we need to better define it into various baskets and then do randomized trials to show where the benefit outweighs the risk.
I'll take the last question. Do you consider using imaging, ultrasound imaging, to decide whether we should see a patient with uric acid value of 10 milligram, with or without comorbidities, but ultrasound shows lot of crystals, a double contour sign in the cartilages? Would that patient be at a higher risk of gout attacks? Would you consider treating them? I'm just throwing a hypothetical question.
So here's a patient with high uric acid, double contour sign, but no history of gout, acute gout in a joint. I think if they have double contour sign, I'd like to aspirate the knee, because I'm going to be discussing therapy in a patient who does not have symptoms. So the aspiration of the knee is not because I doubt the double contour sign, but it's primarily for me to provide evidence to the patient that they actually have gout that's just waiting to show up. The second reason that I would aspirate their knee is also to take away a little bit of the false positive sometimes, because you know that sometimes CPDD disease can cause a false positive double contour sign. And double contour sign does not have 100% specificity. It has a pretty high specificity ranging from over 93 to 95, 96%. But if you look at those series, you don't have a lot of pseudo-gout controls, and you don't have a lot of erosive osteoarthritis controls in some of those series. So I trust double contour sign. If you have clinical history of acute gout, then I sometimes, if I don't have a joint to aspirate, then I'll just go with that as a presumptive assumption proof of gout. But if somebody has no symptoms, then I want some additional evidence before committing them to lifelong therapy. And the patient needs evidence, because this is like telling a patient with high blood pressure at the age of 38, saying your blood pressure is 138 by 78, you need to take the medication. The patient will say, why? I feel fine, because I'm totally asymptomatic. And that's one of the reasons why we have very low adherence with antihypertensive therapy in the US and worldwide, because patients don't feel symptoms. So I believe the aspiration will be done for 2 reasons. And if I see additional evidence of gout, either on X-ray, aspirate, or if I did a dual energy CT scan or some other investigation as some of the emerging investigations, then I think I'll put it together, and I'd probably like to treat that patient, because this is highly likely that patient has gout. Now, even if their aspirate is negative, I would not take that as a strong factor dissuading them for gout diagnosis, because in asymptomatic joints, Ralph Schumacher showed in a study years ago that you sometimes need 2 aspirates. Acute gout, acute swollen joint, negative tap is very powerful. If you've looked at with your eyes, not relying just on the lab, But in asymptomatic joint, I'd like to at least tap twice or get them a dual NGCT or an X-ray evidence. So I'd like to do that. And then my inclination would be, if I find evidence, I would like to treat them.
Thank you, Doctor. So due to lack of time, we are conclude this session. Thank you once more. Sorry.
Thank you.
Thank you all. We move on to the next session. The next topic is gout with comorbidities, practical challenges. The speaker for this session is Dr. J. Binoy Paul. The chairpersons will remain the same.